What I would like to do today is say a little bit about T-cell activation, immune checkpoints, and then, of course, go into PD1 and PD-L1, which is an extremely exciting molecule in the armament that we have now for the treatment of melanoma. So these are so exciting times that the number of treatments that we have are so crowded that it's going to be very important to see how we can use them in the clinic in the best order. And I will show you some of the clinical developments and outcome of clinical trials. So, and already Steve alluded to that, for full T-cell activation, a T-cell not only needs to engage with that T-cell receptor, the MHC peptide complex, but also requires a second signal, usually given by CD28 and its counterpart on the dendritic cells, B7-1 or B7-2. But we also know that there are negative regulators in order to keep the immune response in check. And one of these molecules is, of course, CTLA-4, as shown here, which then probably very early on in the induction of the immune response gives a negative signal. And why we think that is because of that mice that lack CTLA-4 very early on in life succumb to lymphoproliferative disease and infiltration of lymphocytes in all tissues. But there are also other molecules that give inhibitory signals, and one of those that we'll discuss today is PD1 interacting with PD-L1 on the dendritic cell. And if there is an interaction of PD1 and PD-L1, then also a negative signal will be given. Here you see that the intercellular domain of PD1 has an ITIM, so an inhibitory motif, and a switch motif, and it's probably the switch motif which recruits then phosphatases, which will then give a negative signal by shutting down PI3 kinase and AKT. So PD1 was discovered in 1992 by Hanjo and co-workers as an upregulated gene in relation to apoptosis. It's a member of the immunoglobulin superfamily, like I said, with the cytoplasmic domain, which has an inhibitory function. It's inducibly expressed by CD4 and CD8 T cells, but also in KT cells, B cells, monocytes, and subtypes of DC. So probably it's more expressed than, for instance, CTLA-4. It's expressed in both effector and also regulatory T cells. And its interaction is involved, like also CTLA-4, in tolerance, but also in chronic inflammation. And there's evidence that PD1, PD-L1 contributes to functional T cell exhaustion during chronic infection, but also in cancer. So here you see again overview of the T cell here on this side with many of the molecules that have inhibitory capacity, and here the dendritic cell. And apart from CTLA-4 and PD1, there are also other molecules that have inhibitory function that, of course, also will be targeted by new agents. Today we will carefully focus only on these PD1 and its counterparts, PD-L1 and PD-L2. As you can see, it's more complicated, the interaction between PD1 and its ligands, because PD1 can ligate two ligands, PD-L1 and PD-L2, but also PD-L1 can ligate with two different molecules, PD1 and B7.1. And not only T cells express PD1, they also can express PD-L1. So it's a quite complicated system. So where is PD-L1 and PD-L2 expressed? So PD-L1 and PD-L2, also called B7H1 and B7DC, are expressed by cells of the immune system. So on the hematopoietic cells, DCs, macrophages, B cells, T cells, etc. But also in a lot of non-hematopoietic cells, such as the vascular epithelia, pancreatic islet cells, placenta, eye. So areas of our body that need to be protected against immune responses. Expression of PD-L2 is much limited outside of hematopoietic cells. It's PD-L1 is expressed upon stimulation with interferons, and already alluded to the binding partners. We also know that PD-L1 is expressed, amongst others, by these type of tumors, and of course we'll focus today on melanoma. Whether also PD-L2 is expressed in tumors, I think that is now being looked upon by many investigators. So here you see a picture from a study published recently in Science Translational Medicine by the Hopkins group, where they looked at expression of PD-L1 in different tumors, serum melanocytic nevus, which is negative, here a primary melanoma, which has expression of PD-L1, here a magnification of that, and here a subcutaneous metastasis with a very dense expression of PD-L1. So we know that PD-L1 can be expressed by tumors, but although not shown here, also be expressed on benign tumors as well. So if you look at this picture, here's again a metastasis, melanoma metastasis, and here they carefully looked where CD8 T cell infiltration was present, and that they marked that by this line here, and here you see magnification. And interesting enough, you see that there is co-expression of B7H1, so PD-L1, in the same area as also the T cell infiltration is. So apparently in the area where we have PD-L1 expression, you can also find infiltrating CD8 T cells. And when they looked at quite a large number of tissues, so benign nevi, primary melanomas, and also metastasis, you can see if you look at the ones that are PD-L1 positive and PD-L1 negative, that in case of PD-L1 positive, almost 100% of the tissues had a TIL present. Whereas in the PD-L1 negative, the majority did not have any TIL. So there is co-localization and correlation between PD-L1 expression and the presence of TIL. And they even took that a little bit further by using laser dissection, cutting out TIL that were in contact with PD-L1 expressing tumor cells. And if you then look by RT-PCR at the expression of interferon gamma, you can see that only in those tumors that were PD-L1 positive, you can find here expression of interferon gamma, but not in the ones that are PD-L1 negative. Whereas, let's say, CD45 RNA was present in both cell types. So we know already for a long time that the presence of tumor-infiltrating lymphocytes is associated with improved survival. That has been shown not only for primary melanomas, but also for metastatic disease. So that is not new. But what is interesting is that if you now look at the expression of PD-L1, you can see that is also correlated with improved survival. That is not true for all types of tumors. For renal cell, it has been shown that expression of PD-L1 is correlated with poor survival. With a melanoma, it appears to be the opposite. So going back to PD1 and PD-L1 blockade, here again, this cartoon, here you see that in the priming phase, the dendritic cell interacting with the T cell, and we think that here CTLA-4 plays an important role. And by blocking CTLA-4, you can stop early on induction of immune responses. And it's not clear whether it's only induction of new responses or that responses that were invisible, so masked, are now you can now find by depleting regulatory T cells that express CTLA-4. For PD-1, it's different. You see that once these cells in the lymph node have proliferated, they go to the peripheral tissues, for instance, a cancer tissue, and there is the interaction of PD-1 with PD-L1 on the tumor. And by blocking either PD-1 or PD-L1, you can stop this interaction and the negative signal to T cells, and T cell can again become active. So we think that PD-1 we know that PD-1 is highly expressed on tumor-infiltrating T cells, and these are functionally exhausted cells. And blockade of PD-1 and PD-L1 can reinvigorate exhausted TILs, enhancing their expansion, cytokine production, and cytolytic function in order to kill the tumor cells. So there are several antibodies now in development that can do this. So for CTLA-4, there's only one monoclonal antibody presently in the clinic, ipilimumab, but for anti-PD-1, that's different. As you can see there here, if you look at the anti-PD-1 antibodies, so M224 is a fusion protein of PD-L2 and an immunoglobulin that can bind then to PD-1. This is in early clinical development. Nivolumab, we'll come back to that, is an IgG4 human antibody that now is in phase 3 trials. Here's another monoclonal antibody, PD1, from CureTech, which is also in development, in early development, and MK3475 is also now in phase 3. And recently, MedImmune bought this antibody, and also this is in early clinical trials. There are also antibodies in clinical trials against PD-L1, as the MDX1105 from Bristol Myers Squibb, also a human IgG4 antibody, and MPDL3280A from Genentech, which is also in development. And here's another one from MedImmune. So there are many more antibodies in the clinic than is the case for CTLA-4. So let's start with one of the first studies that was published on quite a substantial number of patients, a study published in the New England Journal by Suzanne Topalian from the Hopkins Institute. So in this study with nivolumab, one of the anti-PD1 antibodies, patients were treated for 8 weeks, every 2 weeks, and then after 8 cycles, patients that had rapid disease progression went off study. Also, the ones that had an acceptable toxicity were not further treated but were followed, and the ones that had a response or progressive disease but clinically stable could continue the treatment. The objective of the studies was safety and tolerability of nivolumab. It was an extended phase 1 study. And secondary objective was, of course, anti-tumor activity and pharmacodynamic evaluation. So there was analysis published on 104 patients, and was clinical activity studied in the 94 patients with melanoma. So here are the patient's characteristics, which is typical for this patient populations. So the patient had fairly good ECOG performance status, had prior therapies, mostly immunotherapy, and had also visceral disease in a large proportion of cases. If you look at the side effects, and here you can see the total side effects, so there were any adverse events shown in 80% of the patients. But if you look at the grade 3 side effects, in fact, they were very few. And the ones that were shown was here fatigue, diarrhea, nausea, and low hemoglobin. Also, lymphopenia was found, and lipases elevations were found in these patients. If you look at the response to the treatment, as shown here in this spider or spaghetti plots, you can see here that there is a large change in target lesions after starting off in the study. So the majority of patients had a decrease in tumor size, and this lasted for quite a long period of time. Where even patients had in the beginning increase of tumor size and then a decrease, something that is typical for immunotherapy and was also found for CTLA-4 treatment. Here an example of a patient with a large inguinal node metastasis, which almost completely disappeared upon treatment. And I don't think you can see really well. This patient also developed vitiligo, as shown here with the special light. And you can see here in skin biopsies that the melanocytes, the pigment cells, disappear upon time after treatment with anti-PD1 nivolumab. The study was done with different dose cohorts, and you can see here, so ranging from 0.1 milligram per kilogram to 10 milligrams per kilogram. And there is not a real maximal tolerated dose found. So in all situations, responses were observed, varying between 20 and about 40%. And many of these responses also lasted for a long period of time. The second study I would like to present is a study with another antibody, the MK3475 from Merck. This is also a humanized IgG4 monoclonal antibody with high affinity for PD1 and no cytotoxic activity. So these antibodies were chosen not to induce ADCC and CDC, and with the pharmacokinetics of dosing every 2 to 3 weeks. So again, here were several dose cohorts, in total 130 patients, either EP naive or EP treated in different doses, so 10 milligrams per kg every 2 weeks, every 3 weeks, or 2 milligrams per kilogram every 3 weeks. So patients were screened, then they were biopsied, and then they were treated depending on the schedule, and after 12 weeks response was assessed, And if they had a response to stable disease, they could continue. If not, or had acceptable toxicity, they had to discontinue. And the primary primary objective was immune-related RECIST criteria responses, and secondary objective was RECIST responses according to RECIST 1.1. So what were the toxicities found in this, with this antibody? Pneumonitis, grade 1 or 2, so only very moderate in 6 patients, hyperthyroidism in 11 patients, and transaminase elevations and renal insufficiency in 2 patients. So also this drug is in fact well tolerated. And here you see the waterfall plots, and I think they are extremely impressive and really look like the ones that we have seen for targeted agents, where you can see that the majority of patients had a substantial decrease in total tumor burden, and only a few patients had increase. And if you look at the ones that had prior ipilimumab or no prior ipilimumab, you can see that these are really distributed over both groups. In fact, that so even if you have had ipilimumab, doesn't mean and did not respond, doesn't mean that you cannot respond to this anti-PD1 treatment. I think also that is good news for our patients. If you look here at these swimmer plots, as they are called, you can see here that a lot of these patients are still on treatment, in both groups, so the prior EP treatment and the no prior EP treatment, and that the responses were seen very early on. So if you then look at the different cohorts and the response rate, it appeared that the best responses were seen in this cohort, so 10 milligrams per kilogram every 2 weeks, both in the no prior EP and prior EP group, with response rates of 50 to 60%, which was substantially lower in the other groups. And I don't think it's clear why this schedule is so much better than the every 3 weeks schedule. Here an example of a patient that was treated with a large mediastinal mass, which almost completely disappeared, and the liver metastasis that also almost completely disappeared in a patient that was pre-treated with high-dose interleukin-2 and EP. So in summary, I think we can say that both nivolumab and MK-3475 appear to be highly active drugs. And we are, of course, waiting for the results of the ongoing phase 3 studies, both in ipilimumab pre-treated patients and also as first-line treatment. And compared to ipilimumab, these drugs appear to have a better safety profile. So then, already this was taken one step further by combining nivolumab and ipilimumab. And of course, the question was would that be possible and not too toxic for patients? And this was published in the New England Journal this year with Jed Walshock from the Memorial Sloan Kettering as first author. So again, here different schedules in this extended phase 1 study, varying doses of nivolumab, 0.3 milligrams, 1, 3, and through only 2 different doses of ipilimumab, so the standard 3 milligrams per kilogram and the 1 milligram per kilogram. Either concurrently, but also was a sequence regimen where patients had been treated prior with ipilimumab and then went on to nivolumab. So here's the schedule. So ipilimumab was given 4 times every 3 weeks, as it is always given, but then went on to maintenance after 24 weeks for 8 doses. Nivolumab was also given every 3 weeks, but then for 8 times, and then also went on to the maintenance therapy for 8 doses every 12 weeks. Tumor assessment was performed at 12 weeks by modified WHO and immune response RECIST criteria. In a sequence cohort following prior ipilimumab treatment, patients received nivolumab every 2 weeks for a maximum of 48 doses, so that was a little bit different schedule. So if you look at the patient population, again, this is a normal patient population for melanoma, with a large proportion of patients having 1MC disease, and of course also patients having an LDH which was above the upper limit of normal in about 1/3 of the patients. So concurrent treatment was feasible, although grade 3 to 4 related adverse events were seen in a large proportion of patients, mostly representing a tissue-specific inflammation. And in fact, that is also what you expect in these patients. The most common, though, were asymptomatic laboratory abnormalities, so elevation in lipase, AST, and ALT. The best dose was chosen because in the 3 milligrams nivolumab, the 3 milligrams ipi cohorts that exceeded the MTD for lipase, so they chose to go on further 1 milligrams per kilogram nivolumab plus 3 milligrams per kilogram ipilimumab. In the sequential treatment group, grade 4 related adverse events, 3 and 4 occurred in about 80% of patients. And again, the most common was asymptomatic elevation of lipase. So here you see the waterfall plots for patients in the sequential group. So the ones that had a stable disease on ipilimumab had a chance to respond again, but also some patients that had progressed on prior ipilimumab treatment. But more impressive are the patients that had concurrent treatment. And here you see the different cohorts where you can see complete responses and partial response occurring in these patients. And this is the group that, with the 1 milligram per kilogram nivolumab, that will go further in phase 3 trials. So in 40% of patients had a confirmed objective response, and 31% had rapid and deep tumor regressions, as I will show you in the next slide. Here you can see that in this waterfall plot, that a large proportion of patients had over 80% tumor reduction very early on, which is, of course, extremely interesting in this patient population. Here you see again the spider plots, and also here you see that the majority of patients had a very rapid decrease in tumor load, which lasted then for a long period of time. And here an example of a patient with subcutaneous metastasis and lymph node metastasis that disappeared in a period of 12 weeks. So this combination of nivolumab and ipilimumab is being tested in melanoma, and I already showed you the phase 1 data. There are also a study ongoing now in melanoma, which is a phase 3 trial. But this combination is also now being tested in non-small lung cancer and in renal cell carcinoma. So I think that we're now going to use immunotherapy and also this type of immunotherapy beyond melanoma. So one or two slides about anti-PD-L1. Also there's an ongoing phase 1 trial with this MPDL3280 drug with objective responses in the seen in melanoma in about 29%. Of course, it's a phase 1 trial, so only a small group of patients, especially in the cutaneous melanomas and the mucosal melanomas. There were no responses seen, also the group was small, in uveal melanomas. It has also manageable toxicity. There was no colitis seen and no pneumonitis. And there's now also an ongoing phase 1 trial with the other anti-PD-L1 antibody. Here you see the spider plots of the MPDL3280A, and again you see that a lot of patients have a response with decrease in tumor burden. So this already show you that. So the summary: highly promising drugs, so both anti-PD1 and anti-PD-L1 in melanoma, with response rates varying between 20 to 50%, or even over 50%, seem to to induce less immune-related adverse events. It's as effective also in other tumor types as RCC and non-small cell lung cancer. Combination of anti-CTLA-4 and anti-PD-1 is feasible and highly active, and results, of course, should be confirmed in phase 3 randomized controlled trials. So if you look at future directives, like already alluded to in the beginning, there are other molecules that also appear to have an inhibitory role in the interaction between T cells and antigen-presenting cells, or maybe tumor cells, such as LAG3 and TIM3. And now also antibodies are being generated against these two molecules, and some of these already, especially against LAG3, in clinical development. So I think we will hear much more of immune checkpoint blockades in the future. So you can think of future therapeutic combinations with these drugs, and like I already said, so PD1 could be combined with other immunoinhibitory molecules. CTLA-4 is already given as an example, but also TIM3 and LAG3. But you could also use it in combination with immunostimulators, such as, for instance, anti-OX40, which is in the clinic, 4-1BB, also in the clinic, IL-2, toll-like receptor ligands, but also with, for instance, targeted agents like BRAF inhibitors. But perhaps it can also be combined with standard cancer therapies, such as radiotherapy or chemotherapy, or combined with vaccines. So I think there is a lot of opportunities here to even improve upon this kind of treatment, and hopefully we can even cure patients in the long run. I would like to thank you very much.
Thank you, John, for this very interesting presentation. Are there any questions for John?
Kamara Zaili from Medical Center. So what were the responses to anti-PD1 treatment in patients harboring BRAF mutations? And has these experiments been done in preclinical studies?
I don't think there's a difference in the response rate against these molecules in BRAF mutated patients versus BRAF non-mutated patients. So they are more or less similar.
Okay, thanks.
Tim Morn, Oxford. Thanks for a great talk. Could you just talk a little bit more about how we might move forward with combination of these agents with conventional therapy, particularly radiotherapy?
Well, there are some trials now ongoing where, for instance, ipilimumab is combined with radiotherapy, so either the stereotactic radiotherapy with high doses. And the idea is that by the radiotherapy, you induce already an immune response there, which then will be augmented by the treatment of an immune checkpoint inhibitor. I think these are early days. We don't know exactly what the best combination will be, and whether all types of let's say, standard treatments that we have, radiotherapy, but chemotherapy, will have an effect. We know for some chemotherapies that they appear to induce an immunological cell death and may therefore be preferred over other chemotherapies that don't do that. So I think it's still early. We should try to combine these molecules with standard therapies, but we don't know exactly how to use that combination in the best way.
And the risks of damage to normal tissue when we do either of those combinations?
Well, for the CTLA-4 treated patients, we have seen that if you combine it with radiotherapies, because sometimes these patients during treatment with anti-CTLA-4 require radiotherapy of one of the lesions, that they can have severe dermatitis in that area that has been treated. But it has not seen very consistently. So there are also patients that do not have no skin effect when radiotherapy is combined with anti-CTLA-4. For anti-PD1, I have no experience with that.
Thanks.
Oh, there's one more thing I would like to add, because that has been shown for the combination of radiotherapy and anti-CTLA-4, is that you can have, by irradiating one lesion, you can have what they call an abscopal effect. So that means that also other lesions distant from the irradiated area can then also disappear. That is not very common, but it has been shown for the patients that were treated with ipilimumab. Whether it's also true for anti-PD1 or anti-PD-L1, I don't know yet.
So Patty Johnston again from Queen's. John, can you build on the previous discussion by Steve in terms of GM-CSF, and do you see any role there for combining PD1 blockers and GM-CSF in a regimen going forward?
I think that the combination of these kind of molecules with cytokines is exciting. We know, for instance, that the combination of CTLA-4 with interleukin-2, another cytokine, can induce a very high response rate, much higher than one would expect for EP or IL-2 alone. Steve already alluded to the fact that you don't see a very big difference between response rate, but you see an overall survival benefit. Anti-PD1 and anti-PD1 has not the same toxicity as has been seen for ipilimumab. So whether there you would have the same effect as we see now for ipilimumab, I just don't know. It's something that we have to try.
Savi from Vitromics in the Netherlands. I have a question about combination of these drugs with TKIs like vemurafenib. Is that effective or useful? And
well, we know that there has been a study, a phase 1 study performed in the combination of vemurafenib and ipilimumab. Was published as a letter in the New England Journal. And there they showed that there was quite some toxicity of the combination, especially liver toxicity, and that study was aborted. So that could have something to do with the schedule of how we treat patients with the BRAF inhibitor and the immune checkpoint inhibitor. But you know, mechanistically, you could say, well, by blocking the BRAF mutated molecule, we see that you can induce quite a substantial decrease in tumors, so you will have necrosis, and that may release antigens that would then that could be, let's say, targeted down by the immune system and perhaps augmented by the combination with one of these drugs. But the question is, are these tolerable, right? And so the first indication was that at least this combination was quite toxic.
What about the anti-PD1?
I don't think it has been tried yet. Are you aware of that? There's a vemurafenib. Yeah, that has started, right? Yeah. So there's a study has started, a phase 1 study, where the anti-PD-L1 molecule is combined with vemurafenib.
Okay, I have a last question, and it's patient selection is important because of the treatment is expensive, is toxic, and the PD-1 ligand seems to be an obvious biomarker. What do you think? What's the status at this moment?
What the first indication, it was the first study was published on nivolumab. Showed that in patients that did not have PD-L1 expression on the tumor, did not respond to the treatment. But now we are a little bit further, and we see that also patients that do not have PD-L1 expression can respond to these treatments. So I don't think the jury is out yet. It's going to be complicated. It may also be the density of the expression may influence the response to these treatments. So I think we need a lot more research to know whether this is a good biomarker to select patients for this treatment. At the moment, I would say no.
Yeah. No. Okay, then we move to the. Thank you.
Okay.